Welcome, everyone, to the Unit 1 lecture. This is Dr. Moore. We all try to understand other people. Determining why another person does or feels something is not easy to do. In fact, we do not always understand our own feelings and behavior. Figuring out why people behave in normal, expected ways is difficult enough. Understanding seemingly abnormal behavior can be even more difficult. One challenge we face in diagnosing others is to remain objective. Our subject matter, human behavior, is personal and powerfully affecting, making objectivity difficult. The pervasiveness and potentially disturbing effects of psychopathology intrude upon our lives. Who has not experienced irrational thoughts or feelings? Most of us have known someone, a friend or a relative, whose behavior was upsetting and impossible to fathom. And we realize how frustrating and frightening it can be to try to understand and help a person suffering psychological difficulties. You can see that this personal impact requires us to make a conscious, determined effort to remain objective. Now, the other side of this coin is that being students of psychology, closeness to the subject matter also has a distinct disadvantage. We bring to the study our preconceived notions of what the subject matter is. Each of us has developed certain ways of thinking and talking about mental disorders. Certain words and concepts somehow seem to fit. Now, as you try to understand the psychological disorders we cover and take this course, you may be asked to adopt different ways of thinking and talking from those to which you are accustomed. Perhaps most challenging of all, we must not only recognize our own preconceived notions, but we must also confront and work to change the stigma we often associate with these conditions. Stigma refers to the destructive beliefs and attitudes held by a society that are ascribed to groups considered different in some manner, such as people with mental illness. More specifically, stigma has four characteristics. 1. A label is applied to a group of people that distinguishes them from others. For example, the label crazy. 2. The label is linked to deviant or undesirable attributes by society. For example, crazy people are dangerous. 3. People with the label are seen as essentially different from those without the label, contributing to an us versus them mentality. For example, we are not like those crazy people. 4th, people with the label are discriminated against unfairly. For example, a clinic for crazy people can't be built in our neighborhood. Stigma can lead to discrimination. For example, an individual with schizophrenia may be denied an apartment. The landlord may believe that schizophrenia means the individual would be violent. This belief is based more in fiction than reality, however. A person with mental illness is not necessarily any more likely to be violent than a person without mental illness. Unfortunately, mental illness remains one of the most stigmatized of conditions in the 21st century, despite advances in the public's knowledge about the origins of mental disorders. In 1999, David Satcher, the then Attorney General of the United States, wrote that stigma is the most formidable obstacle to future progress in the arena of mental illness and mental health. And he wrote that in his groundbreaking report on mental illness in 1999. And sadly, this still remains true. The fifth edition of the DSM was unveiled back in 2013 after nearly a decade of multi-level scientific, clinical, and public health review. The DSM-5 is compatible with the World Health Organization's International Classification of Diseases, ICD-10, which is required by the Health Insurance Portability Accountability Act. To accommodate differing DSM-5 and ICD-10 disorder names, the DSM diagnosis should always be documented in medical records in addition to the ICD code. Now, the DSM-5 has been restructured to consist of 3 sections, in addition to the preface. Section 1 is the DSM-5 basics to help you familiarize yourself with how the DSM is organized. Section 2 includes the actual diagnostic criteria and codes. And Section 3, emerging measures and codes. And in the appendix, there may be some useful sections to your study, which include highlights of changes from the DSM-4 to DSM-5, a glossary of technical terms, which you will find very useful in clinical practice, and a glossary of cultural concepts of distress. Now, mental illness is universal. There's not a single culture in which people are free of mental illness, but there are many different cultural influences on the risk factors for mental illness, the types of symptoms experienced, the willingness to seek help, and the treatments that are available. Sometimes these differences across cultures are profound. For example, although mental health care is widely available in the United States, it is estimated that there is only one psychiatrist for every 2 million people living in sub-Saharan Africa. Previous editions of the DSM were criticized for their lack of attention to cultural and ethnic variations in psychopathology. One question that's come up since the publication of the DSM-5 is, are there too many diagnoses? The DSM-5 contains more than 300 different diagnoses. Some have critiqued the burgeoning number of diagnostic categories. As one example, the DSM-5 includes a category for acute stress disorder in order to capture symptoms in the first month after a severe trauma. And should these relatively common reactions to trauma be pathologized by diagnosing them as a mental disorder? By expanding its coverage, the authors of the DSM seem to have made too many problems into psychiatric disorders. Others argue that the system includes too many minute distinctions based on small differences in symptoms. One side effect of a huge number of diagnostic categories is a phenomenon called comorbidity, which refers to the presence of a second diagnosis. Comorbidity is the norm rather than the exception. Among people who meet criteria for at least one DSM psychiatric diagnosis, 45% meet criteria for at least one more psychiatric diagnosis. And some argue that this overlap is a sign that we are dividing syndromes too finely. By this point, you're probably getting an appreciation of the complexity of psychopathology and diagnosis. Diagnosis is an inexact science. Unlike other medical disorders, there are not specific tests like an EKG or a blood test to check for cardiac enzymes or blood sugar levels to confirm or refute a diagnosis of depression or an anxiety disorder. Formulating a diagnosis and treatment plan involves gathering complex evidence from a variety of sources. Diagnosis describes syndromes and not underlying pathology. We really don't have enough knowledge about the causes or etiology of mental disorders. We do need to differentiate between the ups and downs of life, or between what Freud called normal human unhappiness and a mental disorder. A difficult but fundamental task for those in this field is to define mental disorder. The best current definition of mental disorder is one that contains several characteristics, and we're going to take a little time to review those characteristics. The definition of a mental disorder you see here is presented in the 5th edition of the DSM, and I'm going to highlight a couple of phrases. It is a syndrome characterized by clinically significant disturbance. It also reflects a dysfunction and is associated with significant distress or disability. And I want to highlight a sentence here. An expectable or culturally approved response to a common stressor or loss is not a mental disorder. and socially deviant behavior and conflicts that are primarily between the individual and society are not mental disorders unless the deviance or conflict results from a dysfunction in the individual. Now, to summarize the number of characteristics essential to the concept of mental disorder, the disorder occurs within the individual. It involves clinically significant difficulties in thinking, feeling, or behaving. It involves dysfunction in processes that support mental functioning. It is not a culturally specific reaction to an event, for example, the death of a loved one. And it is not primarily a result of social deviance or conflict with society. Now, we can also consider four key characteristics that any comprehensive mental disorder definition ought to have, including distress, disability, violation of social norms, and dysfunction. No single characteristic can fully define the concept, although each one has its merit, and each captures some part of what might be a full definition. Consequently, mental disorder is usually determined based on the presence of several characteristics at one time. One characteristic used to define mental disorder is personal distress. That is, a person's behavior may be classified as disordered if it causes him or her great distress. But not all mental disorders cause distress. For example, an individual with the antisocial type of personality disorder may treat others cold-heartedly and violate the law without experiencing any guilt, remorse, anxiety, or other type of distress. Disability, that is, impairment in some important area of life, such as work or personal relationships, can also characterize a mental disorder. For example, substance use disorders are defined in part by the social or occupational disability created by the substance abuse. In the realm of behavior, social norms are widely held standards that people use consciously or intuitively to make judgments about behaviors, such as whether it's good or bad, right or wrong, justified or unjustified, and acceptable or unacceptable. Behavior that violates social norms might be classified as disordered. For example, the repetitive rituals performed by people with obsessive compulsive disorder, and the conversations with imaginary voices that some people with schizophrenia engage in are behaviors that violate social norms. And finally, dysfunction. This usually is referred to as harmful dysfunction, and it refers to two things. First, a value judgment, that it's harmful, and an objective scientific component, the dysfunction. A judgment that a behavior is harmful requires some standard, and this standard is likely to depend on social norms and values, as we just discussed. Dysfunctions are said to occur also when an internal mechanism is unable to perform its natural function. Hallucinations, hearing voices, could be construed as a failure of the mind to turn off unwanted sounds. Specifically, the DSM definition of dysfunction refers to the fact that behavioral, psychological, and biological dysfunctions are all interrelated. So, why diagnose? Well, first, diagnosis helps us to plan treatment and establish a prognosis. It guides treatment. It helps us formulate an appropriate treatment plan to address anxiety or depression. It allows clinicians to communicate with each other. Common language facilitates communication. It's like a shorthand. People feel less unusual, as a diagnosis can help a person begin to understand why certain symptoms are occurring. It can be a huge relief. People can develop reasonable expectations for treatment. Diagnosis helps an individual make sense of being different or of not functioning like most others, and challenges the feelings of shame, loneliness, and low self-esteem that may otherwise occur.
The need to make a diagnosis before treatment and receive payment from insurance carriers may seem obvious. And diagnosis is important for research on causes and treatment. Defining a diagnosis helps assure uniformity across research results.
In conclusion, everyone agrees that psychiatric diagnosis is not perfect. A fundamental issue is that current classification schemes are of clinical syndromes. Diagnosis is based on descriptive data gathered from clinical observation rather than measurements that relate directly to brain function and pathology. This arises because our understanding of the brain, particularly its higher functions, is less well understood than for many other areas of medicine, where, of course, far less complex organs are the focus of interest. The human brain has 100 billion neurons, each neuron connected to 10,000 neurons. Sitting on top of your shoulders is the most complex object in the universe. Exactly how it operates is still a mystery. It is important to know that there are differences between the DSM classification system used in the USA and the ICD system used in the rest of the world. The DSM is underpinned by a research culture that has sought to have diagnoses as homogeneous as possible for the investigation of treatment and prognosis. The uniformity of diagnosis afforded by the DSM helps assure all researchers are using the same operational diagnostic definitions. Research comparing different treatment approaches can be reliably and validly compared if all use the same definition of the mental disorder being studied. The higher functions of the brain are complex and reflect the interplay of diverse processes from the molecular to the social. A good clinician must be aware of the limitations of the diagnostic categories used and the decisions being made. The DSM is not a cookbook where you simply check off a list of symptoms. The key is to produce a case formulation that goes beyond a simple list of facts and that complements the diagnosis by including information about important clinical variables, such as the tendency to develop suicidal ideation, the lifetime experience of psychotic features, inter-episode functioning, the co-occurrence of alcohol and substance misuse, together with assessments of the patient's life circumstances, relationships, experiences, and personality. Diagnosis is a key component of high-quality, safe care. Diagnosis is a key part of how we communicate with our patients and each other. If we didn't have this, we will have the consequences of the Tower of Babel. We need a unified conceptual system and a shared language. Indeed, any situation in which more than one intervention is available, some form of classification or diagnosis is needed to guide logical decisions about which intervention is better. The importance of diagnosis for patients is growing rather than decreasing. A diagnosis provides reassurance that their situation is not unique, mysterious, or inexplicable, and that there is a body of knowledge and experience that can be brought to bear in providing help. A diagnosis can help reduce inappropriate feelings of blame, perhaps parents believing that their parenting is at fault in a child diagnosed as having autism. It can reduce stigma by explicitly acknowledging the presence of illness and thus that the feelings or behavior cannot be dismissed as a character weakness or simply craziness.